Welcome to the Morning Commute, where I just do a little educational insight on various different body parts, injury pathology, anatomy, a little anatomy, and essentially just do a little sort of mini deep dive on injury. Specifically, in this episode, we're going to talk about low back. So we'll talk about low back anatomy, low back pathologies in terms of pain, and sort of everything in between. I'm your host, Sheldon. I have a background in sports medicine, in strength conditioning, in health and wellness, and that sort of thing. So, I just wanted to use this time as a way to provide some insights in this sort of little live stream slash podcast format and yeah, just kind of go down the checklist. So I'm sure there may be some engagement here in the comments, but as you can obviously see, this is my morning commute. My morning commute to work, and in this time, I just wanted to utilize it to get the most out of it by doing this little mini series here. So talking about low back today. So today we're talking about that. And it affects nearly all of us at some point in our life. Some people like to say that we all have low back pain, but we're just asymptomatic. So it means that we just don't have the symptom of low back pain until we do. So that's pretty interesting in itself. But most cases, with the right approach being not having to get a surgery or not having to go under the knife, however you want to say it, that is essentially what we don't want to do. So with the right approach, with conservative care, whether it's physio, whether it's gym workouts, whether it's choosing a healthy lifestyle, whatever the case might be, it's definitely something that can be managed, um, if at all avoided entirely. So we're going to start off here with why low back pain happens. So it's multifactorial, being that it can be many of a wide range of things, going from posture, movement habits, strength imbalances, strength and lack of mobility. So we'll kind of pick each one of these apart, right? So if you think about posture is going to be a big one because essentially the only time our spine isn't taking a load is when we're asleep. But even then, there's going to be little postural deviations. If you sleep in a bad posture, right, you wake up and your neck feels wrecked. That's kind of one part of it. If you're not supporting your neck when you go to sleep, and then you end up in this sort of weird side bend, like you're on one of those old school phones, right? Imagine you're sleeping like this for 6 hours and you wake up. How would your neck not be sort of stiffened up in that position? So, it's called torticollis, stiff neck. There's many different names for it. But more or less, the idea here is we just want to recapture more mobility. And the difference between, we have mobility and we have stability. We got to know the difference, right? And each one of these things can be affected, from the brain, from the muscles, or even from spinal changes to how we sleep or changes to our posture. So when we talk about mobility, mobility is essentially the free range of motion that a joint can move through unrestricted, right? So like the shoulder, we can move overhead, we can move into extension, internal, external, ABA deduction. Our shoulder can move in many different ways. If there's any sort of restriction within that or any sort of resistance within that range of motion, we got to understand why. Was there an injury? Was there trauma? Is there some sort of soft tissue abnormality or structural abnormality, a bone spur, something that's restricting us from moving within that range of motion? But mobility is essentially the unrestricted range of motion that a joint can move through, where stability is a control, right? Can you control that range of motion? And most people like to kind of intermingle the two, where it doesn't quite work like that, right? Because you can have, like for instance, I can move all the way overhead into a range of motion, Especially if I just went limp arm and someone just guided my arm through range of motion, right? You could probably get some good range of motion moving through that. Doesn't necessarily indicate or doesn't necessarily predicate that I have the stability in that position, right? So the perfect example I like to use in this scenario is you think of it like that person that can drop into the splits, right? They drop all the way down into the splits, right? They got their hands up and they're cheering and they're trying to get the woo girls to go woo. And then what happens? How do they get out of it? They gotta like tuck and roll. They do this awkward turtle roll to get out of it, and then they're cracking up and laughing and saying, "Well, I did it." Well, okay, yeah, sure, but you did it. You did it at the cost of your mobility, but it means that you don't have the stability. If you have to tuck and roll out of it, that means that you don't have the neuromuscular, the brain and muscle control to come all the way back out of it. So we got to think about that. Is it a postural influence? And we take this back to our low back conversation, right? Posture is going to be one of those things that affect the low back pain, whether we get it, whether we don't. Um, and we think about the anatomy of the low back. You think of the whole spine, right? You have your neck, which is your cervical spine. You have your upper back, which is your thoracic spine. And then you have your low back, upper mid back, and you have your mid low back. Your mid low back is your lumbar spine. And of course, you got your sacrum, right? So within our lumbar spine, or low back specifically, five of those transverse processes, or five of those, they come with a transverse process and a disc, right? Five of those levels are contributed to the low back. And we look at the essentially the kinematics of the transverse process, and we look at the essentially the kinematics of the transverse process. We compare a lumbar to a transverse, our mid back to our low back. You look at the spine; they're not going to be the same. There's going to be little morphological. We compare a lumbar to a transverse, our mid back to our low back. You look at the spine; they're not going to be the same. There's going to be little morphological changes because of basically how we've evolved to move. So we can move in all, move forward, we can back laterally, also rotate, right? So because we can move in all of these different directions, our discs and our transverse processes have these different morphological changes. Essentially, if you look at the transverse process, you can see that it's metamorphorotation, right? And if you get like one of those like anatomical, like a spine, you just kind of play around with it. Like good ones, they'll actually are they not sort of fashion where you see the rotation. There's going to be micro rotation that happens at the lumbar, but more than anything, the lumbar is meant to flex and extend, which again, you look at the anatomy and you look at the morphology of those specific transverse processes, they're going to be shaped to do that, right? So when we bend forward, when we bend back, yes, we should be able to bend back because most of us are always bending forward. Um, that is going to come from our lumbar spine. We can also do side glide, right? So kind of like a side bending. That can also contribute from our lumbar spine. But at the same time, you got to be mindful of the very center of it is called the nucleus propulsus, and then on the very center of it is called the nucleus propulsus, and then on usually ends up encroaching on a nerve. So this is essentially like a form of nerve entrapment where the disc is encroaching on the nerve, and now the nerve is sort of occluded, right? So we have an effect on our nerve conduction velocity. So if the disc is bulging on the nerve and you have that nerve compression, then you might start having these symptoms sort of manifest where maybe you have numbness and tingling, maybe you have a legitimate pain symptom, right? Maybe you just don't move as freely. And when you do move into that range of motion, you really start to feel that symptom because when you move, like think of it as a bend, right? You bend forward, you feel a little relief, you side bend, you start to feel a little symptom. You side bend in one way more than the other, you really start to feel it, right? That is essentially like perpetuating that disc bulge because if the disc is bulging over, let's say for example, to my right, and I side bend to my left, right? It would be safe to say that If I bend to the left, I'm putting more pressure on the left side of my disc, pushing it out towards the right, right? You just think about it from a simple logical standpoint, right? I have a disc, it's a jelly donut. If I squeeze the left, right? I'm taking up more space on the left. So now all the content within that donut has to push out in one direction. Simple displacement, right? Compression, squeeze the space out. It's going to go in the other direction, which will be the right. In that same sort of fashion, that's kind of how disc bulges work, right? So we put undue pressure on one specific area of our spine. The disc absorbs that compressive force, and now the disc ends up bulging out into one direction, right? This is an example here. So now we look into essentially like society, like posture that we see in society, right, and how it has an effect on our spine. Again, more specifically here, we're talking about our low back. So we can have these I'll call them postural abnormalities where, people will have this sort of posture when they stand or when they sit, where it's sort of in this anterior pelvic tilted position with a rib caudal sort of, or not rib caudal, ventral position rib cage. So this essentially like creates like an open scissors pattern where this is my rib cage and these are my hips, right? So you see it, people walking around, they got what they call a twerker butt or whatever, where their butt's just kind of sticking out. Again, that's just like something society tells you that you have to do based off of aesthetics. Very much like that cue that you hear when people say to tighten your gut as a way to brace your trunk. It's like the worst cue ever. Say tighten your gut. 9 times out of 10, when I ask someone to tighten their gut, and I won't legitimately ask them, "Do you do this as a bracing strategy?" And I asked the question. I said, What's the first thing that comes to mind of something you have to do when someone says tighten your gut?" 9 times out of 10, people will say they'll suck in their gut and then they'll squeeze. I don't like that because essentially what you're doing when you suck in is you're decreasing the space your diaphragm has to take up in your abdominal wall. So what does that mean? It means you're using an accessory or a secondary stabilizing strategy or a compensatory stabilizing strategy, which is not ideal, right? So you suck in your gut, your diaphragm ascends into the rib cage, you create more space in your abdominal wall, and now this space has to be filled by it has to do something to stabilize, right? But it doesn't have anything to push up against. Think of it sort of like you're wearing a weightlifting belt when you do a heavy squat, right? When you use that weightlifting belt, essentially what you're teaching yourself to do is how to properly valsalva and how to properly use your what they call a transverse abdominis to create stabilization. Because with the weightlifting belt, you have to take a big breath in. You have to basically squeeze your abdominal wall against that belt. And essentially, what you're doing there is what's going to be is what I would consider an ideal stabilizing strategy. It's a little high threshold, but it's more ideal than tightening your gut, sucking in, because you're actually using your diaphragm to stabilize your abdominal wall, your trunk, right? Core, what people like to call your core. I don't like to say core because when people, again, this is another societal thing. When I say core, most people think six pack, and it's not just that, right? It's your six pack or your rectus abdominis, your transverse abdominis, which is the core set of your torso, right? Your quadratus lumborum, which are these side back flank muscles, right? Your paraspinals, right? You have your obliques, your internal and external obliques. All of these contribute to the system of what is known as your core, which is why I say trunk, right? Trunk, it's a lot more concise. It creates the visualization of, either a legitimate car trunk or, for the sake of humor, butt trunk, right? A lot of junk in the trunk. But when I say trunk, I merely mean just the entire contents of your torso, right? So you got your front side, your side, you got your back side, and then you got the sort of like diagonal sort of oblique corners, which are going to be your obliques. Your obliques in the front, your quadratus lumborum on the back, QL, right? And then you got like the deeper stabilizers, right? Like you have your diaphragm, you have your iliopsoas. That's a hip flexor more than anything, right? But it does connect to your low back. But we go back to essentially like societal postural abnormalities, things you see people do, right? So we have this open scissors pattern where we have ribs in a ventral position, right? Ribs flare up, right? Hips are in this anterior pelvic tilted position, right? So hips go forward, and now we essentially create this depression on our low back. So people who are hyperaccentuated, they call this hyperlordosis, medical term, right? Hyperlordosis in the people who are in this hyper being excessive, lordotic position, are going to have low back pain because they're just in this sort of abnormal posture, putting excessive spinal compression via extension, right, lumbar extension, um, on their lumbar spine. So over time, this is going to create an uneven wear and tear or uneven wearing on the low back on the disc. And most prevalent, it's going to be most prevalent on the MRI or uneven wearing on the low back on the disc. And most prevalent, it's going to be most prevalent on the MRI or if you got the imaging on the posterior aspects, right? So posterior aspect being my backside, you'll see a narrowing of that vertebral column because of this excessive compressive force from the posture that you're in, right? So we want to take into consideration the natural shape of the spine, which is going to be an S curve, right? We're going to have a little bit of a kyphosis along that thoracic spine. It means we're going to have a little bit of a forward round on the mid to upper back, and then we're going to have a little bit of a spinal curve on our low back, on our lumbar. Natural S curve, right? Key word, natural, right? It's not hyper, right? So we don't want to have an excessive S curve where now we have way more compressive forces in our lumbar. And what does that mean? Right now, the S is going to be super compensated for, where now our upper back is going to be more in a kyphotic, more in a accentuated kyphotic position because it's essentially accommodating that S shape. So you say, okay, well, what if we entirely nix out the S curves and we just have a vertically stacked spine? Well, that would be ideal, right? Because now you have an even compressive force on all the discs. But now again, you go back to the deal, right? Because now you have an even compressive force on all the discs. But now again, you go back to the natural sort of structure and quality of each disc, right? Each disc has a responsibility, it has its shape and a way it likes to move, right? And because we do have these many directions we like to move in, front, bending backwards, bending forward, bending backwards, bending sideways and rotation, right? We can even move into diagonal flexion and extension, right? Because we have these many different ways we like to move, the natural, essentially an S shape, very mild S shape, right? That's just going to be natural anatomy. You can argue and say, okay, well, what about this? What about an S shape? Very mild S shape, right? That's just going to be natural anatomy. You can argue and say, okay, well, what about this? What about that? What about things like scoliosis? Going to be optimal for you, right? So if you have scoliosis, okay, let's figure out what we can do to make your quality of life, livable. In the most extreme cases, livable and manageable, right? Because again, something like scoliosis, because again, something like scoliosis can be treated on the spectrum, or it can be diagnosed on a spectrum, right? Is it severe? Is it mild? Is it moderate? What are we talking about in terms of daily function? How much does this have an effect on you? Or what can you do? What can't you do? Okay, how can we make it so that you can do what you enjoy doing? Things we have to consider. So posture, that's posture in a nutshell. So now the next one here we go, right? So we're talking about contributing factors, common contributing factors to low back. And we're talking about low back pain right now. Weak core. So we kind of went down that rabbit hole, right? We talked about the trunk, again, the trunk, but we can say that we know based off of the research that prolonged sitting, right? This is going to be another one of the things we talk about. Prolonged sitting can induce fatigue, right? So what we perceive to be as low back pain is actually fatigue. We're sitting for a long period of time, and our low back starts to feel tired. When we start to get some vainness and stiffness, or if we're dealing with chronic low back pain, which is another topic we'll talk about here, dealing with chronic low back pain, it's intermittent and episodic, right? So you sit for a little period of time and it starts to come, you feel it, you stand up, you shake it out, it goes away. That's all that means, right? So it's intermittent means it comes and goes, right? It's episodic means that you have these episodes of low back pain that can happen, but you know how to manage it to help it go away is the idea here. So intermittent and episodic in nature. If it's chronic, you know how to manage it, right? And we know that prolonged sitting is going to turn off your deep core stabilizers. Deep core stabilizers being your pelvic floor, your multifidi, your diaphragm. These three muscles in specific. They go offline when you're seated for a prolonged period of time because essentially those muscles go dormant or they turn off because you're in a relaxed state. Sort of like when you sleep, right? You're not actively contracting any muscles when you sleep. It's all voluntary when you sleep because you're passive, right? You're more or less, unconscious because your body's in a state of restoration and recovery, right? So rest. I would almost consider digest when we talk about parasympathetic nervous system state. That's sort of like your rest, digest, and recover. I would say rest and recover. Digestion is almost in its own category, which is why you would not eat before you go to sleep. Because if you eat before you go to sleep, one, you feel bloated and you just don't want to go. It's hard to go to sleep on a bloated belly, right? And then two, your body has to dedicate energy and resources to process and digest your food, right? So it's safe. It would presume to say that if your body is dedicate is if your body is allocating energy and resource to digestion, it can't allocate those same resources and not energy to sleep and recovery and restoration, right? So there's going to be a little bit of an allocation to that if you eat before you go to sleep, which is why I like to say like rest and recover as well as digest, right? So, and digestion can almost be sort of in the enteric nervous system, right? So we have sympathetic nervous system, parasympathetic nervous system states, right? And then we also have another part of our nervous system, which is our enteric nervous system, which is responsible for gut health. And then we also have another part of our nervous system, which is our enteric nervous system, which is responsible for gut health, right? Every we talk about gut health, we talk about brain gut complex, that sort of stuff. That's exactly what we're talking about. We're talking about the enteric nervous system. But here we are talking about low back pain, and everything in between. So we'll stay back on that topic here. So we've talked about posture. Now we're talking about get a little checklist here. Talking about weak core, right? So weak core. Again, when we talk about core, I don't like to say core. So most people think about their six pack when we talk about core. What I'm talking about the entire trunk, your torso, right? So that talks about your rectus abdominis, which is your six pack, right? Also, we talk about your quadratus lumborum, which is one of your side low back muscles. Your paraspinals, primarily responsible for uprighting, right, for spinal extension. I got an invite to co-host, so that's kind of threw me off there. But I'm on a drive right now, so I don't want to co-host. Nor do I want to co-host because the last few co-hosts that I've had, they've been trolls, so I don't really appreciate that. So I'm just here on my morning commute, and I want to be able, if I co-host, I want to be able to screen, and I want to be able to engage in a conversation. And part of my energy right now is allocated towards driving. The other is towards getting this information out, right? So we're going back to low core to weak core. Weak core, when we're talking about core, we're talking about rectus abdominis as your six pack. We're talking about quadratus lumborum, which is one of your low back muscles. Your paraspinals, which are comprised of three of their own muscles, right? And they help upright your spine in conjunction with your multifidi, which is a deep core stabilizer. And then we have our transverse abdominis, which is essentially the foreset that wraps around our trunk. And then we have our internal and external obliques. Like I mentioned earlier, your internal and external obliques are your front muscles, your front side muscles, and then you have your quadratus lumborum, which are basically the backside muscles. Right. So if we have the core in the system, six pack, paraspinals, QL off to the side, and your internal external obliques on your pocket. So your internal external obliques, they're basically by your pocket, right? And then the reason why we have to is because we have fiber orientation, right? So internal obliques are going to be the ones that kind of like it's like if you're putting your hands in your pocket, right, like that. Those are going to be your internal. Your external obliques are going to be the opposite direction. So cross fiber orientation, you have a lot of muscles that can absorb rotational forces, and the obliques are one of them. Right, so they help you rotate, they help you move in an oblique fashion. So that's your core. Um, all right, so now we're moving on to core lifting mechanics. Core lifting mechanics. That's definitely one, right? So when we think about core lifting mechanics, say for the instance of we're lifting something heavy off the ground. One, we want to make sure we get close enough to the basic support, right? So, or we want to make sure that we get close enough to the object we're lifting, right? This is called your power zone. So if you just quickly Googled power zone, you would have a bunch of images of a dude standing, and then a green box, a yellow box, and a red box drawn around him. The green box essentially illustrates how close something is, or the boxes essentially illustrate how the lever arm, right? So how far, how close you're going to be to when you're lifting something. So ideally, you want to be right in line with when you lift something. It's close. It's going to put the least amount of leverage on your back, right? And you're going to be able to stabilize and have the most leverage on that object because you're essentially in line with it. The further out you go, the more strain it's going to put, and the more it's utilizing your spine as a lever, which is not a good thing. So if we think about, right, if I'm shoveling and I'm reaching all the way far out to shovel, right, you're gonna feel something in your low back, whether it's strain, whether it's a little twinge, whatever the case might be. But if you keep that shovel close in and then you shovel with things within the power zone, right, it's going to be more favorable for you. It's sustainable. It's more efficient, and you'll be able to be more productive because you're able to do more work over a shorter period of time versus having to outreach. Right. So you want to make sure that we're using proper lifting mechanics. We want to make sure we're using our bigger muscles, and we want to make sure the bigger muscles and the whole kinetic chain, and we want to make sure that we're using the optimal stabilization strategy, which is essentially going to be, what I mentioned earlier is like you're wearing a weightlifting belt, you create that Valsalva maneuver where you're pressurizing the chamber of your abdominal wall, right? And then from there, essentially what you're doing is then you're lifting, right? Because now you have a stabilized trunk. You're better at force transfer from upper to lower extremity and lower to upper, vice versa, right? So we think of like a baseball pitcher. They're producing so much. They're producing a high amount of force through their shoulder, but it all starts from that ground reaction force, right? Which is why they wind up, they get their footing in position, right, and then they step through. It's because it's a force transfer, right? From ground to shoulder, and then they sling the shoulder and they throw the ball, and then the force goes from shoulder to ground, right? So it's ground reaction force via the kinetic chain. That's the idea here when we think about force transfer and displacement. So can we effectively stabilize our trunk, right? And in essence, we want to have a stabilized trunk no matter what we're doing. Anytime we're absorbing compressive forces on our spine, we got to have some level of stabilization, right? It's of course not going to be a maxed out effort. So me sitting here in my car right now, I should have some level of activation and stabilization strategy. It's not going to be a maxed out effort here, right? But maybe like a 5% activation compared to if I were to do like a heavy squat or lift something heavy off the ground. I'm going to have a lot more stabilization and a lot more of an effective, not an effective, but I would be a lot more stabilized and rigid in that sort of way because of the task that I'm doing, right? So all that to say is make sure that you have an effective and optimized stabilization strategy when it comes to your trunk for the sake of protecting your low back. Because the diaphragm, in essence, is going to be one of those main stabilizers that help to create pressurization against your spine, which is essentially going to be that anterior protection, right? Because we have all the posterior protection. We're really good at posteriorly protecting our spine via a compensatory stabilizing strategy, which is going to be an extension or an open scissors pattern, right? Compress the low back. We have tons of compression. We have tons of stabilization on the back side of our spine. What about the front side? The front side is stabilized by our diaphragm. And if we don't use our diaphragm, and if we use that tighten your gut cue and suck everything in, now we're essentially creating shear or anterior translation of the spinal contents of the discal contents because essentially we have nothing to protect the front side of the spine. So all this to say is protect the spine. One more mechanism when we talk about low back pain, right? One more thing that contribute to low back pain, prolonged sitting, and we kind of addressed that earlier. So I'll just go really briefly on this one. We know that prolonged sitting can turn off your deep core. Your deep core being your diaphragm, pelvic floor, and your multiply. Your diaphragm is a balloon-like muscle that attaches to your rib cage. When you inhale and your belly expands, that is diaphragmatic expansion. Belly expands, that is diaphragmatic expansion. That is in essence what we're talking about when we say diaphragmatic breathing. Or when you hear someone say diaphragmatic breathing, that's all that is. Can you utilize a true belly breath? Most people use a secondary breathing strategy, which is going to be, again, compensatory, right? Which is going to be through the chest, through the neck muscles. This is secondary here. You think about the sympathetic nervous system, fight, flight, freeze, right? Whenever you're under a threat, your breathing becomes shallow, right? You're a mouth breather, you're breathing rapid. Think about it like after a hard workout, you start mouth breathing, jaws dropped, and you're just gassed, right? Breathing, you're breathing rapid. Think about it like after a hard workout, you start mouth breathing, jaws dropped, and you're just gassed, right? You're breathing through your chest. And it's just a survival based mechanism that we've evolved to create over time, right? So whenever we're in a threat state, whenever we're in sympathetic, if you want to down regulate that, focus on slowing down your breath, focus on belly breathing, and then focus also on nasal breathing. The nasal breathing is hugely tied to the parasympathetic nervous system. The more effective we can nasal breathe, the better of an aspect we can have on modulating our nervous system from sympathetic to parasympathetic, right? Because we can slow down the breath, we can better utilize the diaphragm, right? Try to take a full mouth breath. Then after that, take a full nasal breath. Which one is going to be deep? Which one is going to be deeper for you? And most oftentimes, I've gotten the feedback that nasal breathing, you can actually take a full breath all the way down into your pelvic floor, even. Right, with enough practice, you can actually breathe down and stabilize through the pelvic floor. So you're creating true circumferential stabilization through your trunk. Is the idea here. So all this to say is, if you're sitting for a prolonged period of time, that stuff turns off because you just end up being in a sort of like lax state, and that's because you're in a seated position. Seated position, you relax. You don't think about posture. Gravity takes over, and it just starts to kind of slouch you in a weird position until you become aware of it. And once you create that awareness, you can correct that position, and then you end up, more aware with less back pain. So there's that. So that's pretty much prolonged sitting in essence. Uh, I'm about to my destination now, so I'm just going to kind of finish this up here. But we want to make sure that we're moving, and we want to make sure that we're integrating and utilizing practical movement strategies. So when we talk about movement, right, it's true when they say motion is lotion. The reason being is our joints, right, our structural surfaces have what's known as, this thing called synovial fluid, joint synovial fluid. This synovial fluid is essentially like joint lubrication. And this lubrication essentially helps to keep the joints, um, helps to optimize joint congruency and fluidity when it comes to movement, right? Big global motion. right? Then I got to reach overhead. I'm using my shoulder joint, right? So that's why when you do a warm up, or that's why it's important to do a warm up and not just max out rep one, because you put a lot of strain on your body, on the structures, on your nervous system, and it just takes more time to recover because you're just basically you're not ramping up the nervous system. Essentially, is what it is, right? So if we think about it, kind of like warming up your car on a cold winter day, cold winter morning, you got to turn the motor on. You got to let the motor warm up. You got to let the fluids move around through the motor, right? And then once you're good to go after a few minutes, and the motor kind of revs down, right, and you start going, smoother ride, right? It's like breaking in a new motor is the idea here. You want to do that with your body. You want to warm up the joints, right? So joints that can circumduct, joints that can flex and extend, joints that can rotate. We want to make sure we're doing all of that motion because whatever it is we're going to be doing is going to involve that, whether it's our work or whether it's a prolonged sitting posture. We want to integrate motion. Whether it's a gym workout, we want to integrate a warm up. We want to get the joints warmed up so that there's more fluidity and congruency with the joints when we move, when we load them. Not just that, our nervous system is primed. It knows what we're about to do, right? It's not like it's walking into a blind room it's not like it's walking into a dark room with the blindfold on, right? It has some idea of what we're about to get our body into, right? And again, that is priming our nervous system, priming our proprioceptive system, right? So our awareness for space, spatial awareness, right? How well does our body know where we are and perceive where we are in space and time? That is proprioception. So you think of an athlete jumping in midair, right? They have a really good sense of posture they have a really good sense of proprioception and where they are in space and time because they know when to land, they know how to coordinate the muscle activation so that they don't injure themselves, right? Such is the case on the contrary for someone who doesn't really move a lot, and then they play a pickup game of basketball on the weekend, and they tweak their knee or they pop their calf or whatever the case might be. Their body just isn't coordinated. Their body isn't coordinated and moving like that, right? And it happens in a faster sequence than walking up or downstairs, right? So we walk up and downstairs on the daily, and then we play a pickup game of basketball. A lot more faster. The body has to pick up the speed, right? It has to be able to react. You have to be able to cut. You have to be able to jump. So plyometric ability, right? This all happens very fast, much faster than what you would be doing if you were just walking day in and day out. Walking upstairs, downstairs, whatever the case might be. So we want to make sure that we're primed. We want to make sure we load the joints. We want to make sure we're moving around how we're meant to move, right? So when we talk about rotation, we're warming up the mid back. When we're talking about flexion, extension, side bending, we're warming up the low back. If we're at a job, we're sitting for prolonged periods of time. If we're at a job, we're stagnant, or we're doing a repeated motion for a prolonged period of time, right? Which is in the instance of like a manufacturing or labor intensive type of job. You're doing a specific job task, right? So in the instance of a maintenance person, let's say they're changing out a valve. Let's say their job is one part of their job is changing out their valve, which is like 70% of their job. Okay, so they're going to be doing a lot of reaching overhead. They're going to be doing a lot of twisting, a lot of turning, right? They're going to be having these movement patterns that they do for a repeated, prolonged amount of time per day. Let alone they make a career out of this, and they're in the industry or in that sector for 20, 30, 40 years plus. Right, that's a realistic time expectation for people in this field. And I work alongside them right now in my full time job. I work alongside them. They're in this industry for 20, 30, 40 years plus putting their body through these repeated motions for prolonged periods of time on the day, weeks, months, years, right? Excessive uneven wear and tear on their body, right? And they were never taught how to move, right? That is like the perfect storm for injury, right? For anti resiliency. So essentially, what we want to do is we want to teach them how to move. We want to teach them how to properly warm up, and we want to teach them the correctives. The correctives being the movement. That's going to be the opposite of what they're doing throughout the day. So if they're always bending forward, introduce them to some back bends, right? And what I've seen it time and time again, we do some back bends, and they're so stiff moving back, right? After day one, they're like, "Oh my god, I don't know if I can move like that." Right? They show up for day two, day three, day four. They start to get incrementally more and more extension in their back to a point where they're like, oh, wow, like that low back pain that I had for like years on end, After doing this program for a couple of weeks, that low back pain has really started to turn down. It was usually like a constant 6 or 7 on a bad day, 8, 9, right? And now it's averaging me like a 2 to 3. That is a lot more manageable. Thank you. That is a lot more manageable. I can spend time with my family. I can pick my kid up again. I don't have to worry. I don't have that low back pain. Life is good, and that's the ultimate goal, right? Is figuring out what our lifestyle is comprised of, what our true values are, what our passions, desires, and wants are going to be, as well as needs, right? And trying to check as many of those boxes off as possible. That's the job when it comes to rehab, when it comes to managing a symptom, whether it's low back, whether it's neck, whether it's shoulder, whatever the case might be. It's meeting the person where they're at and giving them an actionable, realistic plan, right? A plan that isn't just driven by the book, by theory, or by putting someone under the knife, and then giving them a plan so that they can self resolve, giving them the plan, the tools, the resources, education, so that they can self resolve. And that if they had a future incident, they know and they have those tools to self resolve on their own, right? Again, it's the philosophy of teaching them how to fish versus giving them the fish. Is the idea here. Oh, it's very key, very key. So we got to be mindful of that. And I'm about arriving to my destination here. So for those of you who showed up, who stuck around, I appreciate you all. I will be doing this for my morning commute to work Monday through Friday. So I'll be having these morning commute episodes where we'll talk about different body parts. If you have anything that you wanted to talk about specific, I also have bring a Q&A, bring your injuries, where I have a little bit of a later start in the morning, and I'm actually able to kind of sit down and then hop on and engage on these live streams. But I'll have a bring your injuries Q&A. So if there's an injury you want to talk about, or if there's something in particular you'd like to cover, you don't necessarily want to engage, but you want to talk about this, or you want me to address this, please do shoot me a DM. Talk about your story a little bit, and then we can bring it up on these future episodes here. But I do appreciate the support, the engagement for those of you who've stuck around for the sake of the conversation. I appreciate you all. If you check out my account, I'm Sheldon.MBT, movement based therapy. That is me. If you want to give me a follow, I much appreciate it. Check out my content, go ahead and like it as well too. Bookmark some of the stuff. And again, if you have any recommendations or suggestions, any feedback, shoot me a DM. I am open to it all. And I appreciate you all for showing up, but I'm just getting to my destination now. So thank you all for showing up. Newbie, what's going on? Appreciate the support. Thank you all for showing up. And I'm about to head into work. So I'll see you all in the next one.